Welcome to the Deep Dive. We're your shortcut to being incredibly well-informed. You know that feeling, right? When you're right on the edge of something big, a discovery that, well, really changes how we see things. Well, get ready. Because today, we are diving deep into the European Society of Cardiology Congress 2025, the ESC. This isn't just any conference, it's the biggest cardiology meeting in the world. And we're focusing specifically on those really anticipated hotline studies. Our mission, pretty simple really, give you the ultimate head start. By the end of this, you'll know the key clinical research, the stuff that's likely to change practice, so you can hit the Congress virtual or in person, already ahead of the game.
And being ahead is important because the ESC, it's just huge. It is the world's largest cardiology society. We're talking over 100,000 members associated with it. The very first Congress was way back in 1952, kind of a post-war milestone, really. Kicked off a whole new era of scientific debate, bringing specialists together globally nowadays. It pulls in over 30,000 people physically from more than 150 countries. It's quite something. It switched to being an annual thing back in the 90s, used to be every 2 years. And remember during the pandemic, the 2020 online Congress had something like 116,000 attendees, just massive reach. And it consistently, year after year, introduces these major studies that get published simultaneously in the top journals and, yeah, often lead directly to changes in clinical guidelines.
That scale is just incredible. Really shows the global nature of cardiology, doesn't it? And the word this year is that the hotlines are, well, some of the best we've seen in a while, covering really different areas of cardiology. Okay, so let's unpack this. Let's jump into the research that could really redefine how we treat heart disease. First up, Friday's hotline. It's a study called DIGIT-HF. Now, digoxin, it's been around forever. So what's the big deal about looking at it again now, especially when heart failure treatment has, completely changed? What's the specific question they're trying to answer that we don't already kind of know?
That's exactly it. It is fascinating. So DIGIT-HF, it's your classic setup, randomized, double-blind, placebo-controlled trial. It's looking at using digoxin in patients with HFrEF, that's heart failure with reduced ejection fraction. So the heart pump is weak. The main outcome they're tracking, the primary composite endpoint, is death from any cause or needing to be hospitalized because the heart failure got worse. But the real point here, I think, isn't just does digoxin work? It's more like, can it find a useful place now, maybe as a cost-effective add-on therapy in this era where we have all these newer, frankly, expensive drugs? Could it be another way to keep these high-risk folks out of the hospital?
Right, HFrEF. And you mentioned the original DIGIA trial back in 97. It showed digoxin didn't cut mortality, but it did help with hospitalizations. So what's fundamentally different since 1997 that makes us need to look again? Yeah. Especially with, as you said, the Fantastic Four now being standard care.
Exactly. That 1997 trial, that was before beta blockers were standard practice for heart failure, and definitely before the Fantastic Four. Our shorthand for ACE inhibitors, or ARBs, beta blockers, MRAs, and those SGLT2 inhibitors became the absolute foundation of HFrEF treatment. So the question isn't just if digoxin works anymore, it's how does it fit in? With this completely different set of background therapies, does it still add anything meaningful? And, we always have to think about safety with digoxin. It's got that narrow therapeutic window. The dose that helps isn't far off the dose that causes problems, so you have to monitor levels carefully, avoid digoxinemia getting toxic levels.
And I heard DIGIT-HF might actually be looking at digitoxin, which has a different way of being cleared by the body. How could that change things maybe for safety, especially with kidney issues?
Good point. Yeah, there's speculation it might involve digitoxin. Unlike digoxin, which is mainly kidney cleared, digitoxin is mostly handled by the liver. So potentially, yes, that could mean a better safety profile, especially in patients maybe with kidney problems. It might reduce hospital stays related to kidney issues. And focusing on hospitalization, that's really key here. It's not just, a stand-in for mortality. Reducing hospitalizations is huge for patients. It makes a massive difference to their quality of life. This study is looking at a really high-risk group, average ejection fraction around 25%, so very poor heart function. Functional class 3 or FEES, meaning they get symptoms easily. These are the patients who often end up back in the hospital again and again, whether they're a normal sinus rhythm or have atrial fibrillation. So the prediction, I think most people feel it's probably neutral for reducing deaths, but potentially positive for cutting down hospitalizations, that would still solidify its role for symptoms and quality of life.
Okay, so after thinking about how an old drug might fit in today, let's switch gears completely. Let's look at the Saturday hotlines, really cutting-edge stuff. Honestly, it was tough choosing just 3. There's so much good data coming, but we picked DAPA-ACT, Odyssey HCM, and Reboot CN. Each one tackles a really unique, important question. Let's kick off with DAPA-ACT. This is about early intervention in acute heart failure. The big question, Is it actually safe and helpful to start one of these newer powerhouse drugs while someone is still in the hospital for heart failure?
Right, DAPA-ACT. It's another randomized, double-blind, placebo-controlled trial. They're testing starting dapagliflozin 10 milligrams daily in patients who are actually hospitalized for acute heart failure. Key things they're watching are, of course, reducing death and heart failure readmissions, but crucially, also safety. Things like blood pressure dropping too low, symptomatic hypotension, or kidney function getting worse.
Yeah, SGLT2 inhibitors like dapagliflozin, they're kind of the darling drugs right now, aren't they? They've really changed things in cardiology and beyond. We know they help decompensated heart failure patients after they leave the hospital, but DAPA-ACT is testing, starting it right during that acute phase. Why is testing it in the hospital so important? And what are the main sort of hopes or fears clinicians have about doing that?
Well, it's critical because traditionally, doctors have been pretty cautious about starting powerful new meds when someone's acutely ill in the hospital. You worry about side effects, right? Like dropping their blood pressure too much or messing with their kidney function when things are already unstable. There were also some early concerns, maybe theoretical, about SGLT2 inhibitors possibly increasing things like ketoacids or acidosis generally. So the study really focusing on safety in these very vulnerable hospitalized patients is absolutely paramount. Our expectation, honestly, it's pretty high for DAPA-ACT. We're hoping for positive results, especially on the safety side. If it's safe, it would really back up this idea that optimizing treatment earlier gives you more bang for your buck. Kind of like we saw with the STRONG-HF study, lets us intervene sooner, maybe change the patient's whole trajectory for the better.
Okay, interesting. So, next on Saturday, Odyssey HCM. This tackles a really fascinating puzzle. Can a drug that's been revolutionary for obstructive hypertrophic cardiomyopathy, can it also help the non-obstructive type?
Yeah, this was a phase 3 trial, randomized, double-blind, placebo-controlled again, looking at mavacamten. Mavacamten is a cardiac myosin inhibitor. Basically, it dials back the heart muscle's contractility. In obstructive HCM, where the thickened muscle blocks blood flow out of the heart, mavacamten has been a game changer. It reduces that thickness, eases the obstruction, and really improves symptoms and quality of life. This trial looked at it in adults with non-obstructive HCM, functional class 2 or 3.
But here's the twist, right? The results from April already came out, and they showed it didn't meet its main goals. The co-primary endpoints related to quality of life and exercise capacity, specifically VO2 peak on exercise testing. They were negative.
Yeah.
So what does that tell us about HCM?
Well, it tells us something really important, actually. It strongly suggests there might be a fundamental difference, physiologically, between the obstructive and non-obstructive forms of HCM. It really pushes us to think maybe these need completely different treatment strategies. We need to dig deeper into research for non-obstructive HCM specifically. It raises that big question. Are they effectively different diseases pathologically? And look, even a negative study like this gives us crucial answers. It deepens our understanding. It really highlights the unmet need for therapies in non-obstructive HCM. Patients with this type often have more angina, more chest pain, and the treatments we use now are often just borrowed, extrapolated from other conditions. So this study, it's really a call to action. We need more research focused squarely on this specific type of cardiomyopathy.
Got it. So a negative result, but still really informative. Okay, final Saturday highlight. Reboot CN. This asks a question that comes up all the time in practice. After a heart attack, an MI, if your heart function is okay, do you really need to stay on beta blockers forever?
Right. Reboot CN. It's what they call a pragmatic trial. Randomized, open label, but with blinded endpoint assessment. Phase fee. Pragmatic basically means they tried to make it reflect the real world. Broad inclusion criteria, fewer restrictions. It's comparing just keeping patients on beta blockers versus stopping them after they leave the hospital. And this is in over 8,000 patients who had a heart attack. Could be a STEMI, the big one with a complete blockage, or an STEMI, often treated with stenting, PCI. But the key is these patients didn't have heart failure before the MI, and their ejection fraction, their pump function, was pretty good, 40% or higher.
And this is super relevant because a lot of the evidence supporting long-term beta blockers in this group is pretty old, right? From before modern reperfusion strategies, before routine dual antiplatelet therapy, and it often included patients whose heart function was already quite weak. We've had some newer studies like Sherry-Do-CE, which didn't show a benefit if the EF was 50% or more, and EBS looked at it after a year. What's unique about Reboot CN is looking at stopping them right after discharge. How could this influence that whole debate about individualizing care versus just following blanket guidelines after an MI?
Yeah, if we zoom out, the study speaks directly to that shift we're seeing in practice. We're moving away from just automatically prescribing beta blockers to everyone after an MI. Decisions are becoming more nuanced based on things like Was the revascularization complete? Does the patient have significant arrhythmias? Are there specific anatomical things like myocardial bridging? It's less about just you had an MI, so you get a beta blocker. The prediction for reboot CN? I'd lean towards probably positive or maybe neutral for maintaining the beta blocker, partly because they included patients with EFs down to 40%, that's sort of mildly reduced range. But it's important the study asks about continuing the therapy, not starting it in the first place. So it might not fully answer the question of whether every MI patient needs to be started on one initially. Ultimately, the takeaway here is likely going to reinforce individualization. You look at the whole patient picture, any stunning of the heart muscle, the risk of arrhythmias, it pushes us further from that one-size-fits-all approach.
Okay, that makes sense. Let's move to the Monday hotlines now. Starting with Parachute HF, this one puts a spotlight on Chagas cardiomyopathy. And the question is vital. Can one of the newer, powerful heart failure drugs help these patients? A group that's often sadly left out of major trials.
Absolutely. Parachute HF is a phase 4V randomized trial. It's comparing sacubitril valsartan, that's Entresto, at 200 milligram total daily dose, head-to-head against enalapril, an older ACE inhibitor, 10 milligrams twice a day. This is as an add-on to standard therapy, specifically in patients whose HFrEF is caused by Chagas disease. The significance here is huge. It involves about 900 patients from over 100 centers across Latin America, finally including a population that's historically been excluded from the big heart failure trials. That alone is a massive step forward for, equity in research.
And Chagas heart disease, it brings its own unique, really tough challenges, right? It's known for causing arrhythmias. It often affects the right ventricle, the RV, quite significantly. And some standard heart failure drugs, which mainly target the left ventricle, can actually sometimes make the RV situation worse. Plus, there's a high risk of sudden cardiac death. Now, sacubitril valsartan, we know it's effective in general HFrEF. It showed a big reduction in sudden death in the Paradigm trial, something like 20%. So what are the hopes specifically for Chagas patients regarding sudden death, and what are the potential downsides or worries clinicians might have?
Well, the hope is definitely substantial, given that proven sudden death benefit in the wider HFrEF population from Paradigm. You hope that translates. But honestly, predictions here are really mixed. It's a tricky one. Sacubitril valsartan is a potent drug that lowers blood pressure. It's a vasodilator. And while very effective, some real-world data hasn't always perfectly mirrored the Paradigm results across all subgroups. Plus, that blood pressure lowering effect, theoretically, it could negatively affect the right ventricle's function because the RV is quite sensitive to preload to the filling pressure. So the critical insight we need is, do the overall benefits of this drug in a Chagas-specific population outweigh these very unique physiological challenges? People are predicting anything from potentially negative due to the RV concerns to being extremely happy if it's positive, because it acknowledges the drug's power but also the specific hurdles of Chagas. This study is set to give a really crucial answer for a patient group that's been neglected for too long.
Fascinating. Okay, beyond these specific hotlines, ESC 2025 has other exciting things happening too. Among the late-breaking trials, one catching a lot of eyes is FBHC. This sounds really interesting. It compares standard cardiac resynchronization therapy, CRT that usually uses 3 pacemaker leads, with a newer approach, physiological resynchronization, placing a lead directly on the His bundle, part of the heart's natural electrical system. How could this potentially change things for advanced heart failure patients who need pacing?
FBHC could genuinely be a paradigm shift, yeah. If this physiological pacing, this His bundle pacing, turns out to be better, or maybe even just as good but safer or simpler, well, it means we might be able to resynchronize the heart's pumping action more naturally, more effectively. That can mean better outcomes, better heart function, but maybe also fewer complications related to placing those leads. It could offer a more targeted, maybe more elegant solution for these very sick heart failure patients who depend on these devices.
Definitely one to watch. And we'll also be keeping an eye on other studies. I saw one on stopping anticoagulation after AF ablation. That's a huge practical question for patients on blood thinners. And another comparing aficamten, a newer drug, against beta blockers for obstructive HCM. That whole area is moving fast.
Absolutely. And something else really significant for those of us tracking guidelines. ESC is publishing its first ever guideline focused on mental health and cardiovascular health. This is huge. It reflects this growing and frankly overdue recognition of how deeply interconnected the mind and heart are. It's a move towards really treating the whole patient.
Okay, so, wow, we've covered a lot. Some of the most eagerly awaited trials, other key developments coming at ESC 2025. This deep dive has hopefully armed you with some critical insights into research that really can change how we practice cardiology. Give you that shortcut, like we promised, to being really well informed.
Yeah, absolutely. Having this context should really help you make sense of the flood of information that comes out of a meeting like ESC. It helps you focus on and really understand the updates that matter most. And, we definitely encourage you to keep digging, keep learning.
So as we wrap up, here's something to think about. As our understanding of these really complex diseases like heart failure and cardiomyopathy gets deeper and our treatments get more and more precise, how do we keep balancing that broad, guideline-based approach to care with the absolute need to tailor treatment for each unique patient? How do we make sure the latest science truly leads to personalized, effective care for everyone?